Good morning, everyone. Thank you for coming. I'm Audrey Warner, the Clinical Director for the Division of Genetic and Genomic Medicine, and it is my pleasure to introduce Damara Ortiz. She's a clinical geneticist here at UPMC Children's Hospital, where a variety of complex and rare metabolic conditions are managed, as well as involvement in cutting-edge research and transplantation to improve the lives of patients and their families. She is also the director of our large lysosomal storage disorder program and has been so for the past 7 years. Dr. Ortiz is the principal investigator for several lysosomal storage disorder clinical trials and registries. She served as the associate program director of the Clinical Genetics and Genomics Residency Program for 3 years and has been the program director for the past 4 years. She has served in a teaching and supervision role since her medical genetics residency, where she was the chief resident. Dr. Ortiz is also involved in the genetic counselor training program, where she serves as the medical director, serving on thesis committees and lecturing. Again, it's my pleasure to introduce Dr. Damara Ortiz, who is presenting Unpacking Lysosomal Storage Disorders, the Legacy of Care in Pittsburgh.
Hi, as Audrey said, I'm Dr. Ortiz, or Damara. I am very honored to give this presentation today. I have been involved in lysosomal disorders since my training, and I'm happy to have contributed to our patients' care and the really deep legacy here in Pittsburgh, which I happily got to dig into for this presentation. I want to welcome the new faculty and the new trainees. We're so excited to have you here in Pittsburgh. And let's begin. So this is just an overview so we know where we're going. Just a little bit about lysosomal storage disorders. I know this isn't always a familiar topic for most people, genetic disorders in general, and then lysosomes specifically. We'll go over some treatment because we can do a lot of things for our patients nowadays that we didn't historically get to do. The new avenue of diagnosis, newborn screening, gene therapy, and our actual long commitment to this here in Pittsburgh, and future forward momentum because it's not stopping and we're learning more as genomic medicine is becoming part of regular care. And of course, welcome to Pittsburgh. As we go throughout this presentation, you'll see little golden bridges because we're the city of bridges, and black and gold. And that will signal that there is a Pittsburgh connection with what we're talking about. So lysosomal storage disorders are a very old set of disorders. They were first recognized in the late 1880s. It was described first as a benign leukemia, but why patients didn't die from their cancer was unclear, though they certainly got very sick and had transfusion-dependent anemias and bone crises. In the same time period, the late 80s, it was recognized that there was this strange rash that happened in specifically men that seemed to progress to other parts of the body. It again took more years and more study to figure out that there is some strange things stored in some of these people, but a connection wasn't quite made yet. So under the microscope, which you could finally use, you could see that there was accumulations of fluffy material. You can see a classic Gaucher cell there full of this pearlescent material. And that took until about the 30s to really recognize what that was as glucocerebrosidase or glucocerebroside. We also recognized more phenotypes where Hunter syndrome was diagnosed in the early 1970s with 2 brothers. Those are the original Hunter syndrome boys. But again, it took more work to figure out what was stored where and what the problem was. In the 60s, so not that long ago, we finally figured out that a lysosome existed within the cell and that this is what was being aberrant in these processes, that it was being stored and distorted and not able to do its function. So Pompe was the first disease where their thought was maybe something was deposited or not broken down and there was abnormal storage, and this might be the reason for these diseases. And then someone postulated, well, if this is a bag of enzymes, maybe an enzyme is broken and we can give it back. And that's what started the idea behind the treatments. And it's a simple idea, but we were actually able to make it work. And it took some time. The first time we were able to prove that scientifically was an accident by a poor lab trainee where 2 fibroblasts were mixed together from MPS 1 and MPS 2, and they corrected each other. Nobody knew why this happened, but they were pleased that it did. And that paved the way of maybe they are sharing a corrective factor. So it took a while to figure out what it was and how to purify it. The first time we got a large amount processed was from human placentas because nobody was using them. And they were able to purify it and fuse it into affected patients, specifically Gaucher patients, and they seemed to get better. But making enough was a problem because there's only so many placentas in the world that you can process. And so in the 80s, they figured out how to clone cDNA, which is a big boon. And we could actually make recombinant enzyme replacement therapy at that time. So in the 90s, and this is where Pittsburgh steps in, we had proof finally through studies at the NIH through Roscoe Brady and John Berenger, one of his fellows, that enzyme replacement therapy did work. And this was through the placental-derived product, alglucerase. And so it was FDA approved. And then the recombinant product, imiglucerase, was approved a few years later and then proved that it was just as equivalent. And the recombinant product took over the placental because the 80s and 90s was also not a great time to use body products. There were other crises going on. And so this has been recognized in Pitt magazine because John Berenger was one of the pioneers of this product when he was training in the NIH under Roscoe Brady. And he is the founder here at Pittsburgh's lysosomal clinical team. So this is the first patient to receive enzyme replacement therapy who had Gaucher disease type 1. He was a 4-year-old boy who had classic Gaucher type 1 and was transfusion dependent. When they infused the product, which you can see Dr. Brady literally pushing in, he got better. And that was something that hadn't been seen either in one so young or sustained. And so that started the modern path of enzyme replacement therapy and other treatment modalities that we'll discuss. So taking it back, what is a lysosome? We only discovered it in the 60s. So lysosomes are an acidified microenvironment containing a ton of enzymes. They all do one particular job, and they're breaking down traditionally complex molecules. These are really basically fancy fats and lipids, some carbohydrates in there as well. But the lysosomes do more than just recycle. They also sense the overall health of the cell. They do a lot of endocytosis and intracellular signaling. They also are a garbage disposal of sorts with autophagy, and they really promote the overall health of the cell. And normally they're this very small, little empty bit of cellular tissue because they're very efficient at their job. When they're sick, they typically take over the cell. This is now your lysosome. Your nucleus is the bottom little spot, as opposed to being the granddaddy of the cell. That's more remarkable. So a lysosomal storage disorder occurs when a lysosome enzyme is broken. That's the classic thought we think of. It's either not working well enough or completely absent. But there can be enzyme activators where the enzyme exists but can't be activated. There's membrane transporters. The enzyme can't get where it needs to go, or the product can't get where it needs to go. Cellular signals being misfired. And there's also post-translational trafficking where the enzyme is processed but can't get, again, to the lysosome where it needs to go, so it can't do its job. So this leads to a lot of altered metabolism and substrate accumulation, which was traditionally the thought of the main problem, but is just one component because it causes a lot of downstream and upstream effects that we are still in the process of figuring out and learning how to treat. So even though there's only 40 enzymes, there's over 70 lysosomal storage disorders, depending on how you define them. So this is just a peek into one way to organize the disorders. We can always get into debates in genetics about lumping and splitting. So some of these would be shocking to be defined as lysosomal disorders, but the main point here is that there is a lot of them, and they are progressive and they have a wide variety of phenotypes. And that's one of the challenges of diagnosis. So what happens beyond just the large accumulation of tissue and compression and cell death is that these enzymes also leak out into the intercellular space, so they poison and harm each other. Apoptosis is damaged. The mitochondria get stressed, but honestly, as a geneticist, they're always stressed when I see them. Intravesicular trafficking and endocytosis is damaged, which is why some of those unusual defined lysosome disorders would be controversial. And externally, the extracellular membrane also gets very blocked and sticky. So you lose local signaling issues and a lack of elasticity and flexibility around the tissue. And of course, in true metabolic disorder fashion, a lack of feedback mechanism leads to more synthesis of the offending product and just a wildfire of worsening symptoms. So this is just a picture of Fabry disease. This is a glomerulus. I know our nephrologists will recognize it. Not everyone will. From the microscope view, you can see these dark accumulations. That's actually GL3, a lipid accumulation. And then in the EM, you can actually see the individual zebra bodies on the bottom. So named because you can see their stripes. So when you have this process going on in your body, there is a huge amount of things that can go wrong because it depends on location and what the offending quote unquote substrate it's supposed to do. So the main hallmarks of these disorders is that they are diffuse. So there's usually more than one organ system affected, and it's progressive. And it's hard because a lot of our diseases are progressive, especially if they're not treated. So you have to entertain that this might be a storage disorder in order to both diagnose and treat it. So if something is getting worse and is not responding, if there's recurrent phenotypes, start thinking maybe this could be a lysosome disorder. We're happy to exclude or include as needed. And if it's not diagnosed, it is disabling. And if it's not treated or recognized, it can be life-shortening. So this is just a cartoon of one of our disorders, MPS II or Hunter syndrome, just kind of highlighting in a simple way the multitude of symptoms that you can see, from stiff joints to neurologic disorder to macroglossia. Recurrent otitis media is a classic, autism spectrum disorder from developmental delay. But you can also have milder phenotypes, which is one of the challenges, is the subtle patients. So this again highlights the spectrum of severity. So the easiest way of thinking about these disorders is that if you have zero enzymatic activity, you will have the classic or earliest presentation, usually the infantile, but it's a spectrum, as a lot of things are right now. And at the diagnostic borderland for late onset, adult onset, non-classic, non-neurologic, everything has too many names, is 10 to 15% of mean enzymatic activity. But that is hotly debated in some circles. So please get us involved if you're worried. So how do you diagnose these conditions? The classic way is history and physical, right? Talk to your patient, look at them, know their history. Subspecialist evaluations are also really critical for us. A lot of our subspecialty colleagues can recognize that something is an atypical presentation of a common disorder. And they can sometimes identify distinctive findings on, for example, X-ray and MRI, which I've shown here. Imaging can be pretty critical. You can see the thickened clavicles that are abnormal from dysostosis multiplex in the patient with mucopolysaccharidosis in their quote, oar-shaped ribs. I don't love these descriptions. One patient who has absent or severely hypocalcified skull membranization. So it's suggestive of perinatal hypophosphatasia. And then the legs on the bottom right have Erlenmeyer-Flask deformity and a fusion of Gaucher cells, the lighter pigment there on imaging via MRI. So those are all sites of possible bone crises and pain. So these are findings that you can find on a chest X-ray or, probably not a head ultrasound, but if you look for them, you can sometimes see things that are unusual and atypical. So when you're diagnosing the patient, the other thing you want to do, if you can, and this is sometimes something we do in clinic as opposed to what we expect you guys to do before referral, is if you have an idea of what's going on, measure the storage material. You can sometimes quantify it, and sometimes just knowing what's stored can be beneficial. This is urinary hex 4 in one of our infantile Pompe patients. The dotted line is what should happen in the age of the patient versus that's healthy versus our affected patient. You can see they responded really nicely to enzyme replacement therapy after diagnosis. You can measure other biomarkers, things like in Gaucher disease, where there is low platelets. When you start treating the patient, those numbers should go up. So it's not specific, but it can be very helpful for diagnostic purposes as well as treatment purposes. And then you can measure the enzyme, and you can measure the enzyme in a variety of ways. It's less common nowadays to do fibroblasts and trophoblasts, but you can. And what you hope for is this. You hope that when you measure enzyme activity, and this is mass spec, that the affected patients have a really distinctly low enzyme amount. Carriers is very differentiated and it's nice and sharp. And healthy people, totally different subset. But it's never quite that way, right? That'd be too easy. So in lysosomal disorders, you also have to worry about the risk of pseudodeficiency. So this is genetic changes that are not pathogenic, do not cause disease, but do cause the enzyme to misbehave or not function well in the laboratory environment. So it works beautifully in your body, but not when we measure it. So this is common in a subset of lysosomal disorders. And as we're doing more newborn screening, we're discovering, unfortunately, lo and behold, it is more common in some of the other disorders. So you can see on the mass spec to the right that patients with infantile Pompe disease, pseudodeficiency with the PSDF in healthy individuals, there's a bit more overlap than you would want for low enzyme correlating strictly with disease. And this is where molecular testing is helpful. So thankfully, most lysosomal disorders are autosomal recessive. Hooray. But of course, there are X-linked forms as well, which cause their own set of challenges. The most common is Fabry, and this is one schematic on how to diagnose a male or XY patient versus a female or XX patient. So you can order enzyme in a male and have an idea what's going on, less clear in a female. If it's within the diagnostic range, great. If it's not, you still have more work to do, then you have to do molecular. In Hunter syndrome, we also have this finding, but the phenotype is a little more distinguishable. And Danon disease as well. There's also less likely to be affected females. Only a few have been described in the bottom disorders. And again, we're here to help in genetics, because even molecular testing is challenging in lysosomal storage disorders. So to take an example of Hunter syndrome, most genetic changes or pathogenic variants are private. So there are some that are recurrent. Most of these are sequence variants, which is good, but 20% are deletions, duplications, and complex variants because of a nearby pseudogene. So this gene contains 97 to 98% sequence homology. It is a evolutionary failed duplication event because, you know, genetics. So sequencing misaligns this data. And next generation sequencing, just because of the technology, which is powerful in most places, cannot pick up these changes routinely. So you do have to sometimes do some old school MLPA, PCR, or a lab that's familiar with these events. But the tricky bit is also that these are causative for the most severe form of the disorder. So if you still think that this is happening, sometimes we have to do more than the free panel. This genetic aberration also happens in Gaucher disease, and that just recently we've been doing NGS panels, I think, the last couple of years because it's been so unreliable, unfortunately. But this is where we as genetics experts are really happy to help because this is complicated. So you finally diagnosed your patient. Now what are you going to do? The hope is you stabilize the disease or improve it, that you make them feel better. And for insurance purposes, that you improve or stabilize the biomarkers, right? Because unfortunately, patient-reported outcomes aren't necessarily what insurance cares about. But we do. So we want more specific patient outcomes, and the FDA is finally acknowledging them a little more regularly. So what do you do for the patient? We talked about one of the forms that I'm most familiar with, enzyme replacement therapy. So you give back what's missing. You do substrate reduction potentially. You reduce the amount of the precursor if it doesn't give them a second genetic disorder. Chaperone therapy, you refold the protein if that's the issue for the genetic change. You can do bone marrow transplant or hematopoietic stem cell transplant, which is the oldest treatment modality, where you replace the lysosomes. And then the pie in the sky that's finally coming down to earth, gene therapy. At this moment, none of these are curative, but they are much better than the natural history of the disease. So enzyme replacement therapy, we already alluded to, was a serendipitous accident in the 1960s. And they tried really hard to figure out how to get this cross-corrective factor, but it really failed until we realized that mannose-6-phosphate was necessary in order to get things into the lysosome. Once that was figured out, we were golden for enzyme replacement therapy. But it's not the easiest therapy. It is an IV infusion every 1 to 2 weeks for the rest of the patient's life. It is several hours. It can be up to 5, sometimes 8 hours. And there are risks and limitations. It doesn't cross into the brain. So if you have a neuronopathic form of the disease, unfortunately, this is not going to help with those symptoms. It doesn't get into every cell type. Chondrocytes just aren't interested. Infusion reactions, some patients have an allergic reaction, but a higher percentage of patients just feel like they have the flu when they get this disorder. It does not feel great. There is inflammatory cascades that are activated from this large, bulky foreign product. And this is also a lifestyle burden. There are needles. You have to get to an infusion center. This is an expensive therapy, which is unfortunately common in our disorders, but we can do something, and we can do something specific. So in the 90s, from Ceridase and Cerezyme came an explosion of enzyme replacement therapies. And as you can see, we've been involved in figuring out if these treatments work, if they're safe and effective, and helping bring them to our patients. And it's been a very busy time in enzyme replacement therapy. There was a thought that maybe we wouldn't need these anymore, but we're still trucking on because we still need to help our patients. So there are still trials happening in order to make the therapies more tolerable and introduce new capacities for them, hopefully crossing that blood-brain barrier, because we still want to get our patients healthier. So another idea was substrate reduction therapy. The idea was to inhibit the synthesis of the compound as long as it doesn't make you sick for another reason. And the goal was that it would be a pill. So we actually were able to produce that clinically. So there are 2 options right now, only for Gaucher disease, oliglustat and miglustat. We were a site for the oliglustat trial for our Gaucher patients. So some of the limitations are we don't have 30 years of data. There are side effects, and you have to be careful about what you take these with. And of course, there's medication interactions because now it's a pill. And all of these are not curative at this point, but patients tend to prefer a pill if they can do one. One of the newest types of products on the market for our patients is protein chaperones. Some of our genetic changes don't produce a truncated product. They produce a product that gets sticky in a different way. And so the enzyme active site is blocked and the body just goes and recycles it right away. And so it doesn't actually get to the lysosome. A protein chaperone helps the protein that's aberrant be folded properly. So it's a friend that keeps it in the right structure. So that's our little blue friend there. If you can get the patient's own folded protein enzyme into the lysosome, this should be better than enzyme replacement therapy. It feels like it should. It should get across all of those modalities that ERT can't. Unfortunately, we only have one of these available at the moment for Fabry disease. And we were a site for that study as well, both in adults and children. And only certain genetic changes are able to respond to this. And it's typically, though not strictly, the milder forms. But still, we're getting improvements. Hematopoietic stem cell transplantation is the oldest and old school form of enzyme replacement therapy. In a way, you are replacing the entire lysosomal system in the hematopoietic system. And you're hoping there's some cross-corrective leakage of these enzymes and proteins. It was not necessarily an accident, but it was first tried in the 1980s with a patient who had MPS I and his mother was the donor. And while he had graft versus host disease, he got much better. And it was a one-time treatment for him. And this is a treatment we offer our patients. We are known for it. We get a lot of referrals in our bone marrow transplant team and through NDRD. And so it's been tried in a number of disorders. Gaucher has fallen off as like the classic presentation of this or treatment of this disease, just because ERT is so effective for type 1, but not 2 or 3. And we are well known for this around the country. It's not curative, but it is better than enzyme replacement therapy if you can get it before the symptoms become severe. It does stabilize a lot of the aspects of the neurologic disorder, but there are risks to this procedure. They're lower here than in some other places, but this is not an easy treatment. So this is just a timeline of some of the disorders that are routinely recommended to consider stem cell transplant on early diagnosis, and some that are more controversial in the more recent years. So one thing that we know for sure in lysosomal disorders is that early treatment is better. It feels like that should be right, but we had to prove it. And siblings helped us with this. So the older sibling that got diagnosed, in that moment as a geneticist, when your heart breaks, when they bring a newborn in or the mom is pregnant, because you know the risk for the fetus or the sibling. You also know that if the child's affected, the sibling is affected, you can help them earlier and they can have a better outcome. So we proved that enzyme replacement therapy improved growth, joint, facial appearance. So this is 2 siblings. One has Morchio A, or no, I'm sorry, Meritolum A. So A, the little girl with the green background, and her brother, who also has Meritolum A. You can see a striking difference in their facial features because they aren't storing as much. But it doesn't change neurologic or developmental declines. The same is true of stem cell transplant. The earlier you transplant, the better. So this is a set of brothers and an uncle in Brazil, all at the age of 7. The little Spider-Man guy had his transplant at about 5 weeks of life, and his brother and uncle did not. I'm not even sure they got enzyme replacement therapy. They might have, but there is a stark difference in their capability and the disease progression. So this spread gave rise to, well, what's the earliest we can diagnose? How soon can we know patients who don't have siblings who lead the way? This is a place where Pittsburgh again shown. So Edwin Naylor trained under Robert Guthrie. And so all of us genetics nerds out there are like, ooh, the Guthrie spot. So he developed the newborn screen in Pittsburgh. He started using mass spec in 1993, starting a program called NeoGen, which has been renamed for other purposes. He brought this to Western Pennsylvania, and eventually it was bought by the Department of Health, well, by Perkin-Elmer, which is now Revity, which is contracted with the Department of Health. And so Perkin-Elmer now does all newborn screening in Western Pennsylvania and most of the state. Recognizing this as a preventative and very efficacious approach to public health, Pennsylvania passed an act in 2014, which added 6 lysosomal storage disorders to the mandated list of disorders. And you can see ideally that there is a clear distinction in affected individuals from a dried blood spot. And so we were off. So newborn screening started in February 2016. I think, 3 months after I took over the program. It started with Pompeii and then has progressed from there. It's typically 2-tier screening. Some of this is modifying over time. So this is what the second screen looks like. You will get a result that says inconclusive, and then it says the enzyme activity amount and what the normal is. And you also get a genetic change. So we get sequencing, thank heavens. It makes things easier, but it doesn't always provide the amount of clarity we would want because of variants of unknown significance. But this gives us a lot more information to approach the parents and the providers with. So this is just a cartoon of what this looks like. So low enzyme, the pediatrician gets the second sample. If it's low again, then sequencing happens. And so it takes about 2 to 3 weeks before we see the patients. But this is much better because they usually don't have a phenotype yet, unless it's infantile Pompe. So the pediatrician and our team are called pretty much simultaneously. And we always call the pediatrician first to see if they want to be the one to reach out to the family or if they want us to do it. Typically, they want us to do it, but we don't want to challenge or cause confusion with that pediatrician and family relationship. So this is just a series of cartoons about how lysosomal storage disorders are becoming more common as part of newborn screen across the country. So every state gets to decide what they want to put on their newborn screen profile. So this is Pompe, which you can see from the dark colors. There's a lot more states that have taken this on. MPS type 1 is also pretty well expanded now as part of routine newborn screening. Krabbe is less common, but growing. MPS 2 is again less frequent, but it was accepted to the RUSP, I think, a year and a half ago. So we're one of the early adopters. But depending on where you are, for those of us who aren't in this room right now, other states are screening for other lysosomal disorders. So we do get called about these sometimes. And we help out some of our colleagues. So you'll notice Illinois is present for all of these. They are a center for newborn screening research. But these other disorders, it wouldn't surprise me if they end up coming. For example, in Harrisburg, Niemann-Pick's type A and B or acid sphingomyelinase deficiency is routinely screened. It's not required, they just do it. So you will sometimes get surprised by what newborn screens roll in the door, even if you're a pediatrician. So this is just some data on our newborn screening in Western Pennsylvania, the referrals that we've gotten here at CHP. You'll notice the big jump in 2019. We were finally able to convince the state that pseudodeficiencies don't necessarily need to be an immediate referral, though we're happy to see them and help the families out. But it's been steady, and most of these patients aren't released because if they have a variant of unknown significance, we have to continue following them and see when symptoms occur or if they occur. So we are continuing to follow these patients and already have a little cluster for 2024. So we've been busy here at Children's and at Pittsburgh and Pennsylvania in general. Starting with John Behringer, who founded the program. Initially, it was called the Comprehensive Gaucher Disease Treatment Center because that's what we had, but he did see other disorders. It was just supportive management and comprehensive management. It changed to the Center for Treatment of Lysosomal Diseases once Fabry treatment became available. And then it was transitioned to Dr. El-Gabari, or Reed. And then I took over in 2016. And we have grown over time, both in scope of practice and in recognition. So we're now recognized as a Lysosomal Storage Disease Center of Excellence. We have been awarded a genetic counseling fellowship. And one of our providers, Nadine, was recently recognized as a national award for an esteemed lysosomal provider. So we're really proud of what we've been able to accomplish here. Our number of patients and scope of practice, as I said, have increased over the years. This is just a gross estimate from what I could get Cerner to let me drag out of it. So we started with Fabry and Gaucher with a few other disorders, and over time we have included more and more MPS disorders. Pompe has expanded. Neuronal cerebral lipofuscinosis with Brineura. We are seeing more and more types of disorders, especially as the treatments have increased and expanded because we are familiar with these treatments and some of their challenges. So we do diagnosis, we do treatment, we manage, we try to identify providers that are willing to learn about these disorders and not just do the routine management, which doesn't always work for our patients. We do genetic counseling. We do research, and we also do outreach. So we try to keep involved as much as we can with what's happening now, how to best take care of our patients, and what's happening in the future. And these patients need incredibly complicated multidisciplinary care. Basically every system you can think of, because these are chronic progressive disorders. And we need help on both the pediatric and the internal medicine side because our patients grow up. So we are constantly looking for collaborators and expanding our support groups. And there are some teams that we are extremely familiar with that also work in lysosomal disorders here, such as neurodevelopment and rare disorders, or NDRD. This was founded here in 2000 by Dr. Escolar, Maria Escolar. Their focus was the neuropathic component of lysosomal storage diseases, which was not routinely treated effectively with enzyme replacement therapy, leading to the boon and stem cell transplant knowledge and speciality here. And she was able to focus on early symptoms to speed the diagnosis even beyond what we traditionally did through subtle things like findings on MRI and auditory changes. And this included both clinical and research approaches. Dr. Rajan has now taken over NDRD, and it's being refocused into both neuropathic lysosomal storage disorders and additional leukodystrophies. And so it's been renamed to Children's Center for Neurogenomics in order to focus on the neuropathic disorders and some of the treatments and approaches we can do for that, given the incredible amount of expertise and knowledge that we have here. So this is just a list of some of the research studies our clinical lysosomal team has participated in. We have a lot of registries, which are important for Pittsburgh because they were founded by Robert Lee, a pathologist here in the early 90s, to recognize that the natural history of these disorders really needed to be described and quantified and followed over time so that we could prove that improvements were being made with our different treatment modalities. So we have a bunch of registries. We've done gene therapy trials. We do oral therapy trials. And we also work with our co-collaborators as sub-Is of some of their projects as well, so that we all get to utilize our knowledge together. And speaking of gene therapy, Pittsburgh was one of the first, if not the first, to be honest. Gaucher disease with Dr. Behringer was one of his passions. And after ERT started, he was also looking into gene therapy. This first trial happened both at the NIH, and we were a subsite where we took genetically modified CD34 cells, which is still a cell that we know and love in gene therapy land. And the transformation of the genetic material was done through the centrifuge. So you can imagine maybe that wasn't the most efficient transformation. There was no immunosuppression. And 4 patients received their own modified cells back after they were centrifuged. There was no toxicity for most, but this was not easy because these patients have bone disease, so Neupogen made them all incredibly ill. And we were able to successfully wean off 1 patient from enzyme replacement therapy. And she got about a year without the ERT on, but unfortunately this gene therapy did not produce a sustained response. And I can tell you about her because she told you about her. We are still following her. And she's now on SRT, but she's doing well, and she's still really proud that she contributed to her community and gene therapy. And so from these early steps, we now have the first gene therapy that is approved for a lysosomal storage disorder. This just happened. Metachromatic leukodystrophy is a neuronopathic lysosomal storage disorder. It is devastating and progressive and leads to early demise. Prior treatments, which will continue, include stem cell transplant and supportive management. That's it. That's all we have. And it was good if you caught it early, but this disease takes a while to recognize because it's neuronopathic. So the gene therapy is lentiviral gene therapy, so much better correction of those CD34 cells. It is, again, autologous, so we're using our stem cell transplant knowledge and abilities there. And They used asymptomatic and pre-symptomatic infantile or early juvenile onset disorders. The results were so impressive that they had to close the study early. It caused gene therapy to occur in Germany for this disorder because there is the difference on all of these pictures. You can see the anticipated developmental track is gray, with the average line as the dashed line, and all of our little dinosaur plots there are the patients that got the gene therapy. You can't see the natural history because it's on the baseline. It is so stunningly different. So we think we should be a site for this, and we are fighting to be because we really should be. Atatarsogene automasel was approved March 18th, 2024. And we have the knowledge, the history, and the ability to do this. So on top of working with the company in order to be a site, we are also working with the Department of Health to add this to the newborn screen. It had been proposed a month before the gene therapy was approved, and it was felt that that was not the best approach if we couldn't give them the best therapy without them going to Germany. And so I imagine it will soon be reevaluated. So another research approach that I think might be a great fit for UPMC is intrauterine ERT. So this is a study that's happening at UCSF, known as the PEARL study. So once you get a confirmed diagnosis, you start intrauterine ERT at anywhere from 18 to 34 weeks. Really what we've seen published so far is in the 30s, but we'll see what Tippy has for us ahead of time. Once the baby is born, they continue ERT and you just keep following them. Oops, oh, somebody's raising hands. We'll wait for that. And this is the first patient to receive in utero ERT. Her history was 2 siblings, one of whom did not respond at all to Lumizyme and still died despite the treatment. The second affected sibling, the parents chose not to do ERT because they were worried it might have caused harm given how poorly the initial sibling had responded. And then when they found themselves expecting again, they wanted a different approach and were willing to try this, and it worked. She is now 5 or 6. She walks, she talks. Her siblings had both died by the age of 2, and she has a couple of unaffected siblings, and she's pretty similar to them. So we still have work to do. There's a lot of cool things going on. We're still trying to make the treatments we have better. We certainly want gene therapy to get better and more precise. We need to know more about these diseases so we can diagnose them earlier and more accurately, and educate other providers in the community like we're doing today. We need to understand the pathophysiology better because it's still feeling very basic, our approach. There's a lot of inflammatory cascades that we're kind of ignoring. Thanks, AI team, for helping us out with that knowledge in rheumatology. And we want to get more involved in the community. And one way that we're doing that is that we are working with one of our family support groups, and there's a Gaucher patient conference in September here in Pittsburgh. So if you have any interest in this stuff, we'll be talking about a lot of this again in a little more detail. Our team has made some changes over the years, but we've always consistently been trying to do our best for our patients, and we're always happy to have more people involved. Yeah, I enjoy the floating heads. I love our team. And of course, the reason we do all of this is for our patients. There's a wide variety of them, and these are some of our littler kids, and some of them that have grown up. And this is, of course, why we really do what we do. I don't know if this video will work or not, but this is a patient who is infantile onset Pompe disease. He was diagnosed on almost day 5 of life. Good job, Audrey. And we started enzyme replacement therapy on day 11 of life, right the moment his newborn screen that was expedited came back. So at a year of life, he should not be walking. He should be on a ventilator or trach. And this is him dancing to Baby Shark. This is a limb girdle muscular dystrophy. He should not be twerking. That's it. Thank you guys so much for coming.